Hello everyone, welcome to Logic Medico. Today's interesting topic is thyroid gland. So, what is the meaning of this thyroid gland? Thyroid means shield like. So, today's objective will be to study the thyroid gland under the following headings: the coverings of the thyroid gland, what are the presenting parts, the relations, blood supply, nerve supply, and applied anatomy. So thyroid gland, as I already mentioned, thyro means shield, oid means like. So thyroid gland is an endocrine gland, anything which pours the secretion within itself into the bloodstream is called as endocrine gland. These secretions are nothing but hormone, and these chemical substances will travel across the bloodstream to reach on the target organ and act on the receptor present on the target organs. So thyroid gland will produce thyroid hormones which are T3 and T4, triiodothyronine, tetraiodothyronine. In addition, the parafollicular cells produces one hormone, calcitonin, involved in calcium homeostasis. So here we can see the thyroid gland, butterfly shaped gland. It is shielding the trachea. It's covering the second, third and fourth tracheal ring. This bridge is called the isthmus, and these are the two lateral lobes. So that is the introduction to the thyroid gland. It is a highly vascular endocrine gland. Extend from where to where does it extend? From the oblique line of thyroid cartilage superiorly till the level of fifth tracheal ring. So to the vertebral level it will become C5 vertebra on the posterior plane and T1 vertebra for the lower extent. So that is extent from C5 to T1 vertebra. It is situated in the anterior midline in the lower part of the neck, the butterfly shaped gland. It is shielding the trachea. So it overlaps the front and side of the trachea. So some of the features of special significance include: it is a unique among all the endocrine gland which manufactures hormones, stores them and then release it as and when required. And this is the only endocrine gland which is dependent on the external environment for its hormone production. So what is the ion on which it depends? It is nothing but the iodine ion. So already the thyroid follicles have got rich amount of iodine within it. In addition to that, the iodized salt or food products, the iodine taken from the bloodstream via the food after absorption, it will be there in the bloodstream, will be actively pumped into the thyroid follicle against the concentration gradient. So it depends on the environment for the raw material, that is the iodine, because it's called triiodothyronine or T3, tetraiodothyronine or T4. Also the amino acid tyrosine, Tyrosine, which is a non-essential amino acid, but the precursor phenylalanine is essential. So that is also in the external environment. Moving on to the coverings of the thyroid gland. There are two coverings, or the connective tissue coverings. One is called a true capsule, which is similar to the skin. The condensation of the fibrous tissue around the gland is called as true capsule, from which the connective tissue septa will enter the gland and divide the gland into lobules. So this is a description of the true capsule. Now what is this false capsule? It is actually like a shirt. So it is not actually attached to our body, but it is enclosing our body. Like that, there will be one fascia like a curtain in front of the trachea. We call it as pretracheal fascia. This pretracheal fascia superiorly is attached to one bone called as hyoid bone and the oblique line of thyroid cartilage. That is the superior extent. As it comes down, it will split to enclose the thyroid gland. So when it's splitting, it will have an anterior lamina and a posterior lamina. Okay. Then ultimately it rejoins below the lower part of the thyroid gland and gets attached to the outer covering of the heart, which is the pericardium. To summarize, superiorly attached to hyoid bone and oblique line of thyroid cartilage, inferior attached to pericardium of the heart. In between, splitting to enclose the thyroid gland. Now, the posterior lamina, which is enclosing thyroid gland, is thickened and gains anchorage onto the cricoid cartilage, and that thickening is called as ligament of Berry. So what is ligament of Berry? It is a thickening of the pretracheal fascia. When it is splitting the thyroid gland, the posterior lamina, So it anchors the thyroid gland onto the ring-shaped cartilage of the larynx called as cricoid cartilage. Ligament of Berry is closely related to the recurrent laryngeal nerve, one of the nerve which supplies all the muscles of the larynx except this cricothyroid. So the ligament of Berry is related to that. Because of this false capsule, whenever we have deglutition or swallowing, the entire larynx moves upwards onto the hyoid bone, including the thyroid gland. So why the thyroid gland swellings or the thyroid gland itself moves upon deglutition? Because of the pretracheal fascia attachment to the hyoid bone and the oblique line of thyroid cartilage. In addition to that, a thickening called as ligament of Berry. So when larynx moves upwards, even the thyroid gland which is anchored to the larynx has to move upwards. As simple as that. Coming to the presenting parts, each thyroid gland presents with a bridge of tissue in the midline called the isthmus and two pyramidal shaped projections called as lateral lobe. So there are two lateral lobe and one isthmus. Rarely there is one projection from the isthmus. It's called the pyramidal eminence. Occasionally this will project further, forming levator glandulae thyroideae. So overall the shape of the thyroid gland is H shape, where the bridge of the tissue isthmus represents the horizontal line in the H. The two lateral lobes represents the vertical line in the H. There is also butterfly shape, where the wings of the butterfly is the lateral lobe and the body of the butterfly is the isthmus. It weighs approximately 20 to 30 grams and rarely accessory thyroid tissues are present. So these are the presenting parts. Coming to the description of the lateral lobes, each lateral lobe, as already mentioned, is pyramidal in outline, is pyramidal in shape. It has got an apex pointing upwards or superiorly, base pointing downwards or inferiorly, an anterior border, posterior border. This is the posterior border. You can clearly see on the posterior border we have two pair of glands which is by the side of the thyroid, so we call it as parathyroid gland. So parathyroid, it's called parathyroid because it is side of the thyroid gland. It is present on the posterior aspect of the lateral lobe. The surfaces include the superficial surface or the anterolateral surface, the posterolateral surface related to the carotid vessel, and the medial surface related to the windpipe and footpipe. So three surfaces: the superficial or the anterolateral surface related to the skin, the posterolateral surface related to the carotid vessel, and the medial surface related to the pipes, the footpipe and the windpipe, trachea and esophagus. So the length or the dimensions of the lateral lobe is, the length is 5 centimeters, breadth is 3 centimeters, and the anterior-posterior thickness is 2 centimeters. The apex of the lateral lobe is pointed upwards and laterally and extends as far as the oblique line of thyroid cartilage. That is the extent of the apex. And the apex gets sandwiched between the inferior constrictor muscle of the inferior constrictor muscle of the pharynx and the sternohyoid muscle, which is a muscle infrahyoid group of muscle. So the apex of the thyroid gland is sandwiched between inferior constrictor of the pharynx and the sternohyoid muscle, sternohyoid and sternothyroid muscles on the other side. To the apex comes the one artery coming from above. It's called the superior thyroid artery. Once it reaches the apex, it splits up into anterior and posterior branch. Superior thyroid artery is a branch of external carotid artery. Coming to the base. Base extends up to the 5th or the 6th tracheal rings. It is related to the T1 vertebra. To the base, it's broader, and we can see one artery on the base. It's the inferior thyroid artery, and one nerve will be there in the tracheoesophageal groove. It's called the recurrent laryngeal nerve. So that is the relation of the base. Coming to the anterior border. The anterior border of the thyroid gland separates the medial surface of the thyroid gland from the anterolateral surface of the superficial surface. So it is related to this anterior branch of superior thyroid artery. Now to the posterior border, as already mentioned, the posterior border separates the anterolateral surface, which is related to the skin, from the posterolateral surface, which is related to the carotid sheath. Also, there is a medial surface present over here. To the posterior border is related the posterior branch of superior thyroid artery, the posterior branch of inferior thyroid artery, and mainly a pair of parathyroid gland, the superior and inferior parathyroid gland. Coming to the superficial surface, this from here till here is the superficial surface. As the name suggests, it is related to the skin. It is also called anterolateral because in addition to facing forward, slightly laterally also. So it is anterolateral surface. It is of course related to the skin, superficial fascia, platysma, and investing layer of deep cervical fascia. In addition to this, it is related to the infrahyoid group of muscles, which include the sternothyroid from the sternum to the thyroid cartilage, sternohyoid from the sternum to the hyoid bone, and the superior belly of omohyoid coming from the suprascapular notch of scapula towards the hyoid bone, the superior belly of omohyoid. You can see the same over here. You can see this is the omohyoid I was talking of, superior belly of omohyoid, sternohyoid, sternothyroid. Here is the thyroid gland. The lateral lobe is covered by these structures. Coming to the medial surface, it is related to two organs, two tubes, two muscles and two nerves. It's very simple. The two organs or the tubes are the windpipe, which is larynx in the upper portion, it becomes trachea in the lower portion. The pharynx in the upper portion, it becomes the esophagus in the lower portion. The demarcation is the C6 vertebra or the cricoid cartilage area. This is the demarcation between the larynx and the trachea, the pharynx and the esophagus. So this is the medial relation. Here will be the outline of the lateral lobe. So two tubes are windpipe and footpipe. The two muscles are, one muscle belongs to pharynx whereas the other muscle belongs to larynx. So this is the muscle of the pharynx, which is called as inferior constrictor muscle of the pharynx, whereas this one is a cricothyroid cartilage. If I want to raise my voice, cricothyroid cartilage. This is the muscle of the larynx. The two nerves are, this one is coming on the outside of the larynx, we call it as external laryngeal nerve. Another nerve goes from the vagus and turns across the arch of aorta on the left side and subclavian artery on the right side and comes back to supply the larynx. It's called recurrent laryngeal nerve. So two nerves are external laryngeal nerve and recurrent laryngeal nerve. Two tubes are footpipe and windpipe. Two muscles are inferior constrictor of pharynx, cricothyroid of larynx. See, there is a rhyme in everything. So this is to show you the same thing: muscle, inferior constrictor and cricothyroid, external laryngeal nerve, recurrent laryngeal nerve. Two tubes, larynx becoming trachea. Behind this, pharynx becomes esophagus. Coming to the posterior lateral surface, it is related to carotid sheath and its content. So what is the content of the carotid sheath here? Medially, it is a common carotid artery. Laterally, it is an internal jugular vein. Between the two, there is one yellow color wire which is going to supply the GIT, gastrointestinal tract, and that nerve is called vagus nerve. So that is the content of the carotid sheath and related to the posterolateral surface, carotid sheath and its contents. Coming to the isthmus, a bridge of tissue which connects the two lateral lobes across the midline is called as the isthmus. It measures approximately 1.25 cm horizontally and 1.25 cm vertically also. The isthmus, anteriorly, it is related to the pretracheal fascia and the infrahyoid group of muscles. Posteriorly, it is related to second, third and fourth tracheal ring. Superiorly, it is related to the anterior branches of superior thyroid artery. Inferiorly, it is related to the anterior branches of inferior thyroid artery. Also, the beginning of the inferior thyroid veins will be there at the inferior border. Rarely, the upper portion of the isthmus presents a pyramidal eminence or the pyramidal lobe. And one of the other variation includes a fibromuscular band which represents the embryological remnant of the thyroglossal duct, and it's called as levator glandulae thyroideae. That can also be present at the upper border of the isthmus. And rarely, the isthmus can be absent with the presence of only the two lateral lobes. So, the blood supply of the thyroid gland can be divided under the following heading: arterial supply, venous drainage, lymphatic drainage. Arterial supply is by an artery from above. Above means superior thyroid artery. Artery from below means inferior thyroid artery. Superior thyroid artery is a branch of external carotid artery, whereas inferior thyroid artery is a branch of subclavian artery, the costo-cervical trunk. So superior and inferior thyroid artery. Superior is a branch of external carotid, inferior is a branch of subclavian artery, mainly the costocervical trunk. Rarely, the arch of aorta can also give a branch towards the isthmus, which is called as arteria thyroidea, or you can call it as thyroid artery. Occasionally, accessory branches supplying the trachea can also come and supply the thyroid gland. Venous drainage is by similar name veins, but additional to that there will be one extra vein, middle thyroid vein. The superior thyroid vein is closely related to the superior thyroid artery. It is like a newly married couple, it's next to one another. The superior thyroid vein ends up in the IJV, internal jugular vein. Okay. The inferior thyroid vein, you can see that here, inferior thyroid veins are very far away from the inferior thyroid artery. They are like a diversi, the inferior thyroid veins. They end up in brachiocephalic vein. What is this brachiocephalic? Brachio means arm. The vein of the arm is subclavian vein. Cephalic means head. The draining vein of the head, that is the brain, is internal jugular vein. Internal jugular vein joins with subclavian vein to form brachiocephalic vein. The inferior thyroid vein ends up in brachiocephalic veins. They are very far away from the inferior thyroid artery. Last but not the least, the middle thyroid vein. There is no artery as such like that. So this middle thyroid vein can be considered as widow, like a widow, similar to a widow. No artery, no partner is there. So middle thyroid vein directly ends into the corresponding internal jugular vein. Why? It is next to that. That's why. Okay, that is about the venous drainage. To summarize, superior thyroid vein, middle thyroid vein, inferior thyroid vein. Superior and middle thyroid vein drains into the corresponding internal jugular vein, whereas inferior thyroid vein ends up in the corresponding brachiocephalic vein. It is far away from the inferior thyroid artery. Come to the lymphatic drainage. The lymph nodes can be in front of larynx, in front of trachea. So we call it as pre and paralaryngeal lymph nodes, pretracheal and paratracheal lymph nodes. Also, it goes to the deep group of cervical lymph nodes called as jugulodigastric lymph nodes. The nerve supply of the thyroid gland is both from sympathetic and parasympathetic nerves. Come to the last but not the least, applied anatomy. Congenital anomaly, ectopic thyroid gland can be present in the posterior triangle of the neck or in the retrosternal region. Rarely, the thyroid gland can be present within the tongue, resulting in massive tongue or macroglossia. That is, failure of the descent of the thyroglossal duct results in the formation of the thyroid gland within the tongue, resulting in a condition called lingual thyroid. Lingual means tongue. Thyroid means thyroid gland, instead of developing in the neck, it starts developing only in the tongue because the thyroglossal duct failed to migrate. After the thyroid gland is formed, the thyroglossal duct has to disappear. Rarely, the duct persists and it forms a closed sac like an acne. It bulges like this, which is called the thyroglossal cyst. Failure of disappearance of thyroglossal duct results in thyroglossal cyst. This cyst, when they ask the patient to protrude the tongue, it will move. That shows that the thyroglossal duct is developed at the junction between anterior 2/3 and posterior 1/3 of the tongue. At that junction, there will be one foramen, tiny foramen blind, it's called foramen cecum. But if the middle portion of this thyroglossal duct persists, it results in a cyst formation called as thyroglossal cyst. Opening of the cyst either to the interior into the windpipe or to the exterior onto the skin, which is more common, is called as thyroglossal fistula, where pus infection of the thyroglossal cyst results in opening of the cyst to the exterior, resulting in a fistula. Fistula is a tract which connects either two internal tubes or a tube to the exterior. Thyroglossal fistula is a sequel of thyroglossal cyst. Here we can see the thyroid gland. Isthmus has been absent. Here you can see the lingual thyroid. Okay, you can see this thyroid gland, lingual thyroid. The tongue has become really massive, macroglossia. Okay, this is a lingual thyroid. Sometimes instead of being projecting in the tongue, it can be underneath the tongue itself, sublingual thyroid. Next to the hyoid bone, in front of the larynx, prelaryngeal, normal thyroid position. It can be retrosternal or substernal. The cyst can be at various levels. Usually it is determined in pediatric age group. Thyroglossal cyst may be diagnosed later at age. On protrusion of the tongue, it moves forward. If the cyst breaks and opens up like this to the exterior, resulting in drainage of pus, we call it as thyroglossal fistula. Goiter, abnormal dilatation of this thyroid gland, abnormal enlargement of the thyroid gland is called as goiter. Just because it is enlarged, it doesn't mean always it will produce hypersecretion. Rarely, the non-functional thyroid gland can also be enlarged, resulting in goiter, just in a compensatory manner because of the excessive TSH in hypothyroidism. It is trying to stimulate, so thyroid follicle is rapidly undergoing proliferation without producing secretion. So even in hyposecretions, there will be enlargement of thyroid gland. That is called as goiter. So this goiter, this is CBME, okay, extra points. This goiter presses upon the medial relation. Let's see what it will tell. Why this person with goiter will have difficulty in breathing? Because it presses on windpipe, the larynx and trachea. This person with goiter will have difficulty in swallowing. It presses on which tube? It is esophagus. Okay, pharynx and esophagus. In the posterior lateral surface, this person may have giddiness. It presses on carotid vessel. Excellent, carotid vessel. This person may have hoarseness of voice because it presses on vagus nerve, which gives recurrent and external laryngeal nerve. So he has got change of voice. Maybe dilated veins are present in the neck because of retrosternal extension and pressing on the brachiocephalic vein and superior vena cava. So there is venous congestion and edema of the face. All these are symptoms of the enlarged thyroid gland because thyroid gland presses, or the enlargement is more on a deeper plane or a posterior plane than on the anterior plane. The other finding of hyperthyroidism or excess secretion is called as thyrotoxicosis. Is this condition is called as exophthalmos. That is, we can see the limbus, the sclerocorneal junction of the upper area, usually not seen, but if it's seen, that means there is protrusion of the eyeball. And this person, if you shake his hand, the person will have warm and moist hand, showing increased BMR because thyroid hormone is involved in maintenance of BMR. Here there is hyperthyroidism, so more amount of BMR, more heat is there, so warm and moist hand. And if you ask the person to stretch his hand out, there will be to and fro movement of his finger, which is called as tremor. And if you auscultate for him, his heart rate, blood pressure, everything will be high. It's tachycardia, he will be hyperactive. Whereas in hypothyroidism or myxedema, the person has got abnormal deposition of fat because BMR is low, low pitched voice similar to a child, dwarf, and IQ may be low, especially in pediatric, resulting in cretinism. In adult, we call hypothyroidism, in adult we call it as myxedema, in child we call it as cretinism. Why does the thyroid swelling move upon deglutition? Because it is attached, pretracheal fissure is attached to the hyoid bone, oblique line of thyroid cartilage, also due to ligament of Berry. So whenever we have a swelling in the midline, we ask the person to swallow his saliva. If it moves, that means it is due to thyroid gland. The direction of enlargement of the thyroid gland is more so on the posterior plane and not superior plane because the pretracheal fissure is thin on the posterior plane. So pressure on this can cause a stridor, that is noisy breathing, that is compression of the windpipe. The person may complain of dysphagia because compression of foot pipe, change of voice, compression of vagus, the recurrent laryngeal. Thyroidectomy, removal of the thyroid gland surgically is called as thyroidectomy. We can do partial thyroidectomy, only lobectomy, okay, or complete thyroidectomy. Following complete thyroidectomy, we have to replace the thyroid hormone, so hormone replacement therapy with L-thyroxine drug. We should make sure that we preserve this parathyroid gland, otherwise the person will end up in tetany. It is calcium deficiency. Ligate the superior thyroid artery as close as to the gland as possible. Why? Because the external laryngeal nerve is plastered to the superior thyroid artery. It will diverge only near the apex. So, ligate the superior thyroid artery as close as to the gland as possible. Whereas inferior thyroid artery should be ligated as far away as possible to prevent the injury to recurrent laryngeal nerve. Because recurrent laryngeal nerve will be diverging away. So, if you want to preserve external laryngeal nerve, ligate the superior thyroid artery as close as to the gland. Want to preserve recurrent laryngeal nerve, ligate the inferior thyroid artery as far away as possible from the gland. Thank you for watching and learning from Medico. If you benefit anything from this, please press the thumbs up icon and share this video with your friends. Have a happy learning and share this video so that others also can learn better. Thank you once again. Kindly subscribe to our channel.